going. Hello, everybody, and welcome to this episode of Weight Loss Winformation. I think this is going to be one of my very favorite podcast interviews, and I am pretty sure you're going to find it to be one of your favorite podcast episodes. Tonight, we have a woman who, to me, I have so much respect, admiration for, and I will preface this by saying I believe that Dr. Vera Tarman is one of the foremost experts in the world about food addiction. So if you're not familiar with Dr. Tarman, you might be familiar with her book, Food Junkies, Recovery from Food Addiction. And I know there's 2 editions, and I want you to know, Dr. Tarman, that at any time I talk with a patient, I send them a list of references, and your book, the picture, all of it is front and center because I think it is an absolute must read for anybody who even has a hint of thinking they have a food addiction. So welcome.
Well, thank you. What a wonderful, I'd love to meet that person that you were talking about.
Well, you look at her in the mirror every day, I am sure. So your first book that you did with Dr. Wardell was great, but this second edition, I can't even begin to tell listeners, and you've got to read this book because you include interview information with specialists from all over the world. And I want to tell you how admirable it is that you don't say, this is the way it is. You share their perspective on the various aspects of food addiction, and then you'll say, here's what I think. And I love that.
Yeah, thank you. Well, it's such a complex field now that I would be really isolating myself if I just said it's my way. Like since that book even, there's been so many more people getting in the field with their slight alteration. Doesn't have to be full moderate or abstinence, or maybe we need to include more work on trauma. Like it's quite varied now.
It really, really is. And in the what I want to do is, of course, people struggle with this. Do I have a food addiction or do I not have a food addiction? And I think, when people talk to physicians, they hear a lot about, well, there's the hormones, right? The ghrelin, the leptin, the insulin, and that's what makes you want to eat more. So that's could be part of the picture, but you and I believe there's more to the picture. So let's just start with that.
Okay. Can I, before we do that, just mention that I am getting a 3rd edition coming out at the end of this year, and that's the one where I'll be including some of the information on the GLP-1s and where they fit into this whole picture. And I think I'll talk about intermittent fasting, because those are things that have come up as more issues since the 2nd edition. But anyway.
I love that, and I'm really glad that you're including the information in the GLP-1s because, I mean, that's where the medical community is at, for sure. And so we have to address that because I think there's a big lack, although it's getting better, of education amongst a lot of professionals, all of the professionals who treat weight issues.
I really want to talk about that, but let's go to your first question because it'll build to that, because we have to talk about that. But just ask me the first question again. It's about the hormonal aspect.
So there are the hormonal issues, and some people might think, well, I just have too much of this or not enough of that. It's not really a food addiction.
Yeah.
So that is a reality for some people. There are imbalances in those hormones, but that is not the same as food addiction. So how do you explain that to people?
So the way that I explain it is I say that there are actually 2 dimensions. One is the hormonal, or what we call the endocrine, or in the literature, the homeostatic model. And it believes that, its premise is that it's a disalignment of hormones. Normally we would have hormones that, when we're hungry, the ghrelin goes up and tells us we're hungry, and then leptin, when we eat, satiates, and then we stop. And it's a kind of finely tuned system, like a yin yang, like, the ghrelin leptin balance, which makes our diet or our appetite and satiety well regulated to food that we need, to the energy expenditure that we need to have enough food for. But what's happened is the ultra processed food industry, which is very clearly trying to misalign them because they want people to eat more and to eat their particular product. So they deliberately um, misaligned our hormones. I mean, how deliberate is it? I don't know if they're thinking we're going to do this, but they're thinking when we do this, people eat our foods more. So it's, anyway, the end result is the processed food industry is making foods that are misaligning us. And therefore, if we stop eating those foods or take medication or do surgery, we can kind of self-correct to some degree. Well, no, not self-correct. We can correct to some degree. And that is true. So a person can be so misaligned that they can eat and look like a food addict. They're eating, like, what is food addiction? But basically, when a person is eating foods where they don't have choice anymore, despite negative consequences. And yes, you can do that with the homeostatic model, understanding the hormones. And that's why the keto diet, the low carb diet, the GLP-1s, which we'll talk about later, work because they're fixing that. But we know, and this is the whole reason why I think you, Connie, and others who speak about this in the advent of the GLP-1s, we still belong because there's another dimension that doesn't really address this homeostatic model, and that's called the hedonic model, or what I call in my book the neurochemical model of looking at the addiction, the dopamine surge whenever I take a drug, whether it's alcohol or food, sugar, refined carbohydrates, that ups the dopamine spike and then gives an excess amount of dopamine, which then kicks into gear an addiction-like phenomena that is on top of or alongside, not instead of, alongside the homeostatic model. So then two things are happening to the person who's eating ultra-processed food. And that therefore, and the medications, the GLP-1s and the surgeries and any other medications, that if they don't address the addictive piece, it only lasts for a short period of time. So we say you have to look at that second piece because it's a different phenomena. Because you can be, people know this, you can be full, you're not hungry, your ghrelin, leptin, your energy expenditure, everything's calibrated and you're fine, but you still want to eat. You want to eat because you're unhappy and you want to lift your mood. And so you're taking a food drug to
food drug.
yeah, to change that, and that's a whole other. We have to address that angle as well.
So can I just clarify, just to make sure the listeners are on the same page, and also for myself? First of all, I want to say that you explain this biological thing better than, any other physician, because I can sort of understand it, but it's still very complex. So with food addiction, you is there always that component of those biological chemicals being out of whack? The leptin, the ghrelin, the insulin?
They don't have to be,
Not
but what
necessarily.
you don't have to be. So you can be. Uh, Put it this way: if when we are eating real food, like I'm assuming you are, I am. I'm still a food addict, and
Right.
I'm not going to obsessively eat because I'm not eating the foods that are demanding that. However, if I were to have just I don't know, a candy bar, like not just a teaspoon of something, although over time that would add up. But if I were to have a candy bar or a can of pop or something like that, it would wake up something that's not hormonal yet, but it would wake something up, just like the alcoholic, that first drink. It's
Mhm.
like, oh, yeah. And that might get them started off to drinking. If it doesn't do that, it will at least plant the seed of thought in their head of, I had that drink and now I remember what that's like. And that sort of what we say, that produces a phenomenon of craving. That is there even if you're homeostatically normal.
Right.
That's
Right.
why it's dynamics.
And
But
that's why it doesn't make sense to people. It's like, you already ate. Why are you hungry? Or,
yeah,
you
what is
know, addiction is a difficult thing to understand if you
it?
either don't if you haven't experienced it yourself, or been close to somebody, because when you talked about that first drink, I can tell you that the first time I drank, it was over. You mentioned not having an off switch,
Uh-huh.
and that is exactly what it was like for me. There was no off switch.
Yeah, exactly. That's exactly a perfect description. There's no off switch. And so having that candy bar would turn that switch on. And even though you might not binge that day, it's in your head irritating. It's an irritant. It's a
Yes,
nausea. It's a food noise. And it gets bigger the more you try to fight it off. Like that's the phenomenon of addiction. That's not got to do with the hormones. It's got to do with the neurochemistry. But the interesting thing is, so I talked about these two different dimensions. They actually are intertwined in the back, so that when my ghrelin is up or my insulin is up, like I'm hypoglycemic, I'm crashing and I want sugar because I'm so tired and faded out and I need something because I had, a big pancake meal earlier, I'm going to crash. Um, there is a backdoor connection to dopamine that gets turned on. So essentially, you're turning the switch on, even hormonally. If you eat something that is high in sugar and you have a sugar crash, because when you're crashing, our brain is telling us you need fuel, glucose, and if you don't have fuel, you'll die. So your hunger will start to develop. This insane hunger of the hypoglycemic hunger will make you we call it hangry, right? Agitated. I want something. But
right.
the other thing it does is it makes you really want sugar. You start thinking about it. You start fantasizing. You start planning. And now you can't do your work because all you want to do is the fantasies of sugar plums and fairies are in your head and are dominating you. And that's dopamine. And it's meant to be there because when you're hungry, your body doesn't want you to just carry on and ignore the hunger. It's going to intentionally, the lower the fuel is and the gas for your brain, the more you're going to think about food so that you can fuel up. So dopamine has a back door, and if you are continually eating foods that spike your sugar and then you crash, that's a good way to become addicted. Like because they're two separate things, but they get closer and closer woven together, and that's essentially how a person, even if they're not genetically predisposed to becoming food addicted, just by virtue of continually eating that food regularly, constantly, a lot of it, you develop an addiction. Just like if you start smoking, a couple of cigarettes, you're not a smoker. But if it's a pack a day for a week, well, all of a sudden you're a smoker.
Do you think it's a fair statement to say, so for example, like myself, that first drinking experience, there was
Yeah,
no off switch. So I'm
genetic.
that's genetic, right?
Yeah, now some people would say genetics. Well, what about early childhood experiences? What about maternal influences? Or there's all that stuff for sure. There's predisposition. You were obviously, for some reason, predisposed. But I would put my money on genetics as number one. And if it's
Mhm.
not, then I would ask, okay, what else is going on?
Right. Okay. So there's that.
Or, Connie, can I just say another thing?
Yes.
Or maybe there was a predisposition because you were already an addict of sugar. Like a lot of people who are alcoholics, if you
Oh
look back
gosh.
in their food history as a child, they were the ones that were binging and eating a lot. So in a sense, the addiction pathway started then without people knowing that's what it was. Then they started drinking and
Exactly. Exactly. And it took over. Yeah. And absolutely. And you mentioned this in your book. It's like when people stop drinking, like people in the treatment center will even suggest they eat candy to kind of uh, minimize the withdrawal effect, because the brain is seeking that same rush, doesn't matter what it comes from, which leads to transfer addiction, which we'll talk about later. But so you can have a genetic predisposition. Do you think that if a person does, or if they've got this trauma and maybe, well, let's forget about that piece for a minute, but you could have a predisposition genetically. But let's say you don't. Would it probably take longer to develop the
yeah,
addiction?
think so. I think that it would probably take longer, unless you have some other predisposing factors. Then yes, you get like a previous addiction or living in an environment where you had to do something to survive in that environment. But
Right.
with all other things normal or the same, I would say that a like genetically predisposed would take a little bit longer. But it's just that the one who's predisposed just gets it more quickly. It only took you one drink. A lot
Oh,
of people,
instantaneous.
it takes about 10 years, and they drink a lot in university, but then when they get married and they're now unhappy in their job or something's happening, and then the booze starts to up, that's when they get because it's the amount of frequency and the amount that often turns the moves from sort of harmful use to addictive use. But with some people, like you're describing yourself, that happened right away.
Yeah. So with food, would it be fair to say, and tell me if I am so off base with this, but let's say somebody starts out as an emotional eater, that food was a source of comfort and, it made me feel better. And not all emotional eaters fall into addiction, but some do. And is that a dopamine issue?
Yeah, because food is inherently pleasurable and gives comfort, depending on what the foods you eat. Now, if you're eating real food, not junk food, it's still food is pleasurable. Like I eat good food, but I look very much forward to my meals. Like there's not like, oh my God, food is fuel, and I've just got to
Right.
push through it. No, no, no.
Exactly.
I think it's totally fine to enjoy our food, and we do enjoy our food because that's meant to be. And uh, it does give a sense of comfort, a sense of nurturance, like good things. So does exercise, so does socializing, so do a lot of things. I
Mhm.
mean, they're all we get a dopamine rush from them, which is intentional, so that we do them. Like otherwise, I wouldn't eat if I didn't enjoy it. I wouldn't talk to people if I didn't need them in some way. It's a lot of work and trouble to hang out with people and cook and
So true.
we get something out of it. So we're willing to push through the hardships, the mini hardships to get the bigger reward. And that's dopamine, and that's meant to be that way. But when you're in despair, then you're going to use that naturally good thing that you get uh, in excess. That doesn't necessarily mean if it stays within that context. Um, like I do think there's a kind of line. I would say that that's possibly verging on harmful use, or
Right.
what I call in my stages of food addiction, the first or second stage. But there's a certain point when you go along the continuum, when if you eat enough and fast enough, and it's usually it's speed of intake and amount of intake that the brain starts to neuroadapt. There's so much dopamine, it has to readjust because we have everywhere in biology, including in this, but everywhere, this concept that's called homeostasis. The body always wants to go back to the same. So if I'm living in a flood of dopamine because I'm depressed and I'm eating a lot of ice cream, um, 1 or 2 weeks of that, maybe I can get away with. But at some point, the brain is going to go too much of this dopamine, and it's going to start to have you develop what's called a tolerance. You
Mhm.
neuroadapt, called downregulation of the receptors. It's a physiological change so that excess amount starts to feel normal. That's the beginning of the addiction phenomena. And at some point, there's so much neuroadaptation that changes that it changes forever, I think.
I
So
think
that
so too. I agree with that. So in other words, in what you hear a lot is it takes more to get the same effect. So,
exactly.
it used to be 2 scoops of ice cream and you're, like, relaxed and you got that feeling of well-being or whatever, but as you develop tolerance because you're having higher and higher dopamine surges, then you require more and more and more. Now you're on the path to addiction.
And then you need the cookies on top of it. Then you need the syrup on top of that, and it's like it's never ending. Yeah,
Yep.
and that's when comfort eating becomes or harmful eating becomes. I mean, first of all, food is comfort, but then it becomes harmful, and then it becomes addictive. So if comfort eater were to stop and say, okay, it is just 2 scoops of ice cream, and I'm not going to have the tub, then I would say, okay, they haven't crossed the line into addiction yet. And if they can actually stop, because remember addiction is inability to control intake despite negative consequences, that's the person that's gone over the line. But if the person is still able to stop portion control or something like that, then I would say, okay, don't push the envelope here. If
Right.
you want to be able to eat this stuff, actually, I think why would you want to? This stuff is so unhealthy. But if you want to, the occasional birthday or something, and you just social engagement, and you keep it to that, and you haven't yet crossed the line, then you're not a food addict. Maybe not yet. But
Right.
everybody is a
Could
food addict.
develop into that.
Absolutely.
Do you think there are people for whom, and I think you kind of, in your story, as you shared your story, it's kind of like maybe you were born an addict as well, because it was like almost instantly, it was like, oh, it's just never enough.
Yeah, of whatever. Yeah, I mean that's often what we talk about, the addictive personality. It's not really an addictive personality, but it is a dopamine. I would say hypersensitivity that you capture this sensation and want this sensation more than somebody else. Because there's a lot of people who are content. I mean,
It's a foreign concept, isn't it? It's like, what do you mean you just had it's like, what for me, it was like, what do you mean you left half a glass of wine? Why would you do such a thing?
huh, yeah, or even nothing. I'm just good,
Yeah,
doing here.
exactly.
Yeah, so they're not as likely to be predisposed.
Question about the dopamine, because I know in the book you talk about and you explain dopamine, serotonin, and endorphins. But we hear all the time about addiction being associated with dopamine. And there's that book, Dopamine Nation, and
Yes,
how we have gotten so accustomed to this instant gratification that we are becoming multiply addicted, if that's a
absolutely.
word.
Yeah, well, or transfer addicted, or yeah, absolutely. So
The
what's
role
the
of serotonin and the role of endorphins in this addiction process.
so this it's a good thing because it's this balance, this yin yang idea. So remember, I'm talking about the hormones, the ghrelin, leptin in the neurochemical model where we're looking at dopamine. Um, it's understanding that just of the three that I talk about, and there's more. There's oxytocin, and there's adenosine. There's other neurochemicals, but if you just get those three, that's the main. You get a lot of the story. And the way that I explain it is that we need all of them intact, and dopamine is the one that is the mostly understood in the concept of addiction. But the way that I phrase it is dopamine is the understanding of addiction, and serotonin is the understanding of recovery. And
Okay.
dopamine and serotonin work together. They're like the yin and yang. Dopamine gets me up out of bed in the morning to want to do, to may check off the list and to buy my shopping. Like for example, I don't buy shopping on the weekend anymore. I buy shopping every day because I get to go out and hunt and gather. It's a little mini dopamine hit to just pick up my lettuce
Mm-hmm.
rather than the big thing, whatever. So anyway, it's an example of managing dopamine. But dopamine gets you out of bed to do things. But at the end of the day, you don't want to do anymore. You want to be content. You want to relax. You want to be with your nest. Like dopamine gets me out of the nest, hunting and gathering, doing what I got to do. But then I want to come home and rest and relax and be with my people, my tribe, my whatever. And I don't want to do. I just want to be. And serotonin is the neurochemical of contentment and satisfaction. And they work really well together. What happens in addiction is the dopamine is huge. And you've heard this phrase, the opposite of addiction is connection, right? This is a common
Right.
phrase. So the opposite of addiction, which is dopamine, is connection. That's the serotonin. And you don't want to treat the addict by more dopamine. People say, can't you just give me dopamine so I don't have to go out and buy it or eat it? I don't. I want to actually reduce the dopamine because it's already too big. And it's
Right.
neuroadapted and tolerant, and your brain is already saying enough of the dopamine. What you want to do is go to the appropriate antidote, which is serotonin. Um, and that is, interestingly enough, all of the recovery tools that are in 12 step and in a lot of treatment programs, group therapy, that's serotonin, prayer, which spirituality is it's a bit of oxytocin. Well, it's more than just serotonin, but serotonin based because it's
Mhm.
group focused, service, um, satisfaction, gratitude. That's all serotonin. And because
Nice.
what you're trying to do is reduce that dopamine because it's become inflated, and you want to boost up the serotonin, which has become diminished. And I think it's a great way to see those two. You want to put them back in their right balance, the right alignment.
I love that. And some people, I think, have gotten so uncomfortable with the the comfort, the serotonin
Yeah,
level, the
yeah,
equilibrium, that it's
yeah,
constantly seeking that high. And so I think with weight and weight loss medications and weight loss surgery and uh, people don't understand the transfer addiction because they don't understand they have an addiction in the first place.
right, right. Their dopamine is high, and if you cut that source to fill up that void because you created this um, blunting effect. That's what part of what tolerance happens is a blunting effect. So if you quit your drug, you're going to look to something else, anything that essentially is a kind of hunting gathering type of what's new, what's exciting, what's big. That's all dopamine, and you shut one door and it literally will go out and look another way. That's why you can't give dopamine because there is a drug. It's called L-Dopa. We give it to Parkinson patients who have
Right.
dopamine in a part of their brain, but it would not help. It would just actually. We know that when you give dopamine to elderly people, they become more interested in gambling. They become more
Exactly.
impulsive. It's not good. What you want to do
Right.
is give them instead serotonin, and that means that you have to, this is where therapy comes in, teach the person this is no longer an exciting life. Life is only meant to be exciting sometimes. Most of the time, it's meant
Exactly.
to be, contentment. I just do what I do, and I'm not, that's very hard for the addict because they want lights and
Right.
blazing.
They want the
Exactly.
high. Yeah. I
And
think that word contentment is such an important word to teach people
yeah, yeah,
because
and
people
also
think they want to be happy. Well, sure, we want to be happy, but happiness is a fleeting kind of thing.
yeah. Well, the other is happy too, but one dopamine happy is the I want. It's always looking into the future, the next drink, the next bite. Because oftentimes people, when they're in a food binge, they don't actually like the food right now, but they keep eating because they keep thinking the next one will be amazing. The next bite, the next type of donut, the next this, the next that.
Right.
Are they actually enjoying the feeling of getting fuller and full? No, no. But they keep
Right.
thinking. It's the same with the alcoholic or the whatever, the drug user. You're not actually enjoying that moment. It's the anticipation of the excitement. But what the
Yep.
thing that serotonin does is it brings you in the now. So dopamine is future based and serotonin is now based.
I
So
love that.
grounding, yeah, connecting, being still.
Yeah. So a lot of people, in the weight loss world,
Yes.
that word addiction is thrown around without a lot of accuracy. How can people kind of say, "Ooh, maybe I do have a food addiction"?
Well, it's thrown around with with uh, with a dismissive and stigmatic nature. That's my experience
Sure.
anyway. It's like, oh, you don't, and the rebuttal that I often get is, look, the person's already dealing with the stigma of obesity. Why would you add addiction to it? And what I would like to say is, addiction is a phenomenon like depression, anxiety. It's very common, and it's we think about the extremes like the crack addict with their pants half down in the park. um,
Right.
this is the addict is also the person that's in the grocery shop looking, piling up their grocery cart with all sorts of things that are impossible to eat all at once. But it's an addictive experience. I think what I would like to say is let's normalize addiction and take the stigma away from it because it's just a phenomena that's in response to too much that's happening, overstimulation. And we don't have a hard time saying I'm overstimulated. It's a
Right.
common way of saying I'm overstimulated by too much.
Oh, that's a great way to say that.
Yeah,
Yeah.
let's
And
destigmatize the word.
when you said that, when you said, "Why would you wanna use the word addiction?" So the person can heal.
Yes, yeah.
Until the idea that what was going on with me after many issues, and we'll talk about eating disorders and that crossover too in just a minute, but until it was like, "Oh my god, I'm dealing with an addiction." I couldn't heal because
Right.
I didn't know what I was treating.
Right. And the thing that's important to hear about the addiction is if you normalize that term a bit, and then just to say, when I say I have an addiction, what it means is that my brain has adjusted in such a way that I am now programmed to want more than I need. And even when I stop, I don't have a control over this anymore, this phenomena. I do have
Right.
control over um, how to remove myself from the situation and do treatment. But the actual phenomena, this is it's like saying, um, I've got diabetes. Like, um,
You should be able to control your insulin level. No,
right.
you can't.
No, you can't. You can't. You can't. And you should control your weight. You can't control your weight like that. Those are outside of our parameters, as is addiction. But what you can do is learn what will create the insulin rise, what will create the weight rise, and start changing the externals around you. So you
Exactly.
have to recognize that you're dealing with a dynamic, a biological dynamic that is bigger than willpower.
Yes, and, like you said, it's like a runaway train, and I love the use of the word, "Your brain gets hijacked." It's
Yeah.
like no matter how much logic you have or how much willpower you try to throw at this, it's bigger than all of that.
Yeah. Yeah, it's a good example that people might understand is when a person gets really angry, they say things that they would never otherwise say. And you say, you could say, you always wanted to say that or something. No, no, like something happens when a person gets so angry that their
Right,
brain is hijacked by the anger and they
right.
do and say things that they would never otherwise say, which is why we say you're only human. We understand that. Well, it's the same
Mhm.
thing happens with addiction. It's like a kind of anger.
Yeah.
Something like that overtakes. So what do
Mhm.
we do with anger management? We don't tell the person, don't be angry. We say, what are the things that you can do so that you don't rise up to that level? Like you look at the externals around you, and that's the same thing with addiction.
Right. I love that. That is so true. So, you don't choose to have an addiction. You either have the predisposition for it, and then you kind of, in this bad terminology, but you feed it, whether it's food or alcohol or whatever, or you develop it by providing your brain with that over saturation of dopamine, and then your
Yeah.
brain just takes over and wants it.
Yeah. And if we truly did live in a society like maybe we did 100 years ago, where you only had this stuff once in a while, like you only drank during like religious ceremonies or some drugs, just religious ceremonies, where you only ate at holidays, we wouldn't become addicted. It's the fact that it's become so ubiquitous all the time. Sometimes that's all the person eats, not even real food. That's where the problem is.
Yeah, I agree, and that's where the whole environment and the whole food, what do they call that? Engineering, how they engineer, and you mentioned in the book the bliss point and the hyper palatable, which everybody has heard, but how would you describe that?
Well, that's the classic example of what the food industry does. This is like how they are pushers. They like Michael Moss in his book Sugar, Salt, Fat, or Fat, Salt, Sugar. I think it's Salt, Sugar, Fat. Talks exactly about that. How the bliss point was created by people determining. If you put a certain amount of sugar in a soft drink, it's it's sweet, but you can put too much sugar and then it's too sweet. So he developed this scale that he called the bliss point, where you reach that perfect point of palatability, like it's just delicious, and now you want more of it.
Yeah,
And he said it's not just in pop now; it's in every food, including ketchup and soup and potato chips. Everybody's looking for that perfect amount of salt, sugar, fat. And
yeah,
that is a deliberate attempt to make you buy more than you need.
that's right,
It is no different, it is no different than the drug user who's standing by the welfare line when the guy gets his check and they come out flush with their check. And the drug dealer is right there saying, hey, here's the stuff. It's no
that's
different.
right. It is not any different, and I think that I've come up with this idea about we need to have compassion, right? We have compassion for people with all kinds of diseases, and
Yeah.
we have to have compassion for others and compassion for self, along with accountability. So we can't just say, "Oh, gee golly whiz, poor me. I live in this society where everything's set up against me and I've got the predisposition."
Uh,
So I have to have compassion. Yes, that's true. And it's
yeah.
not fair and it's all those things. But I also have to take responsibility.
That's where the treatment comes in. That's like the number one thing, right? Is acknowledging, yes, I am vulnerable. I am biologically vulnerable to these foods, but I do have a choice. I can remove myself from the grocery store. Like
And
I
then
can.
we get our favorite response from our patients who say, "Well, I can't just quit eating. I don't have to drink alcohol,
Right.
but I can't just quit eating." To which we respond,
You 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 can eat as many carrots and lettuce and broccoli as you like, but you don't have to eat
"Don't
refined
have to eat
carbohydrates.
sugar and refined carbs."
Those are not food.
Absolutely.
Let's call it what it is. They're not food.
Right. I love that, and I know it kinda ticks people off, but it's the truth, right? It's like, I'm not gonna sugarcoat that for you. Yeah, if you've got, an issue where you're thinking about sugar morning to night, let's see what happens when you don't ingest it.
That's right. Right. And you're going to have withdrawal, which is because it's a drug. But the good news is, like any other drug, you get past that point of withdrawal and then you're back to you're not going to crave it. You won't be addicted.
Yeah. And like you, I agree that it's a permanent change in your biology. So, there are people in the professions who say, you know, you can learn to drink socially. Well, I guarantee you, I could go out and have a drink at dinner, but it wouldn't be very long before that option was like, "Okay, there's my solution, and I'm right back at it."
Yeah.
I believe that, and I think it's the same with sugar.
And it's the same with a lot of, not just addiction. If you look at illness like diabetes, once you're a diabetic, you might be in remission. Like that's why I say we are in remission. You might be in
Correct.
remission and your sugars are normal because you're eating well. The moment you go crazy and eat, your tub of Haagen-Dazs, your sugars are back to 20. Whereas somebody else, it doesn't. It's not. It's they're not yet. They haven't made that adaptation. So I think that we say there isn't a cure, but there is remission.
Right. And, like, you mentioned too in the book, it's like, so you're abstinent from sugar, and then maybe you give in at a birthday party or whatever, and maybe you don't go crazy at that point in time, but now you got the nagging in
Yeah.
the brain. It's you're thinking about it, and in the studies of addiction, you and I both know that anticipation is part of the addictive process because you can get the high, the dopamine hit looking at billboards.
Yeah, that's right. And I wrote an article actually to try to capture some of the phenomena that happens. Like, why is it that it sets up the phenomena of craving when you just have one? If you've had a history of addiction, it's like there's memory traces, associations that are quiet, but when you set them, it's like a kindling thing of a fire. It the kindling is always there, and all you need is the oil and the match, and you've got a fire. Whereas somebody else, you have to build that kindling up. And so there's this residual memory, so that when you are stressed or something happens, that kind of opens up, and it's like there's this dopamine um, calling for this stuff, and this is not within our control. That's why we often say in the addiction treatment platform, putting down the drug is only the first step. Now you have to live a life so that you don't pick up again because you're living with a phenomena that is always ready to go.
Mhm. And I think for our patients who do struggle with food addiction and, that regain issue,
Yeah,
and them not understanding that there could be an addictive disease process going on there as well. And for them to understand that when you take that first sugar thing, your brain wants that high level that it had become accustomed to, which you mentioned. It wants the top of your tolerance. It doesn't just want a little bit.
No, that's right. That's part of the thing that's happened. You go right back to where you left off. Um, yeah.
And
But we
I
let's talk.
think go ahead.
I want to say, let's make sure we talk about the GLP-1s.
Okay, let's talk about the GLP-1s and then some eating disorder stuff too.
Sure, whatever.
Okay, let's go to the GLP-1s because they're so out there in the world right now, everywhere.
This is an interesting thing. Um, I lurk on a lot of Facebook doctor groups, bariatric groups, or just doctor groups now. And I don't say much because I get such uh, negative commentary back. But
Right,
anyway, they're almost, it's almost like there's this giddy phase that's still the euphoric phase of the GLP-1s that have come on the scene. What, maybe 10 or 5 years for sure in Canada, maybe 10 years in the US. And so lots of people are still in that giddy, euphoric first stage of, wow, look at this drug and look how great it is. They're talking about it themselves, how they use it amongst themselves and how excited they are. And I keep waiting to hear, we all know, especially in addiction, this is a euphoric phase. It's only the first phase. Then there's the next phase, which is you need more to get the same. And then there's the next phase, which is nothing I do, and it's not working anymore. I know that that's going to happen eventually. Of course, the pharmaceutical industry is going to keep trying to address that by upping the dose and changing
right.
them.
Altering.
Yeah, yeah, which is exactly what's happening now. But
Mhm.
anyway, the GLP-1s are very exciting to clinicians to the point of excluding everything else. And partly because, number one, they do change that homeostatic model that I talked about earlier. They adjust the insulin and they adjust the ghrelin leptin so that you can have a little bit of junk food, except that the other thing that happens is you don't want to eat that much, so you don't even want that. And then the other thing they do is it also goes to the hedonic model, the neurochemical model, and it flattens the dopamine. So it's kind of like it got two birds with one stone, which is great, except that it has a lot of side effects, and if nothing else, it's temporary unless you plan to stay on it the rest of your life. And
Right.
the thing that's sad about that is you won't be able to stay on it the rest of your life because, well, first of all, I think it's like 70% of people stop by year two because they can't tolerate the side effects. Like
Mhm.
the compliance is not that high after, like, once they lose the weight, it's like, I don't want to feel sick anymore. Can I just
Mhm.
lose the weight and now go back? And that doesn't work.
Right.
So the drug companies are going to have to keep chasing to try to make the focus is all on the GLP-1s because the initial looks really good, but those of us in the field know it's a temporary solution. And first of all, let's just put it right out there. uh, you can get the very same effect, both the homeostatic, get rid of the insulin issue, diabetes, obesity, get rid of your cravings by just stopping the food, the sugar, in the space of 3 to 4 weeks, and then you have to stay off of it. That's the challenge. But
Right.
you can get the same effect. You won't get it as quickly and as dramatically, but you'll get the same effect with no side effects.
Yeah.
Um, so you have to say that the medical world doesn't want. I think maybe now even more than before. Before they just said it doesn't work. It's too hard. And we would say then it's too hard if you're doing it on your own. You need community. You need places like this platform and 12 step, whatever to make it easier. But now they say it's too hard, and why would I? Because I got the medication.
Exactly.
Yeah.
And my greatest frustration in this whole thing is that the clinicians are providing
Oh,
no support, no education, no, you need tools so that you can eventually
yeah.
taper off of this. And you need, oh my gosh, it makes me crazy. It really, really does.
I mean, there are some people who are, I would call that ethically using the drug. Like, I think it's possible to use the drug ethically as a
Agreed.
bridge, a bridge,
Agreed.
but I don't think that's happening very much.
Right. I
Especially,
mean, when you can buy it at Costco or you can buy it at, the med spa, who's educating
yeah,
you? Who's giving you the tools?
right. And there are some pretty serious side effects.
For some people there are, and I'll tell you, I've worked in the bariatric surgery field for so many years. And I would say that at this point in time, with the advent of the GLP-1s, I would say a handful of people opting for bariatric surgery have not ever tried a GLP-1. 95% of people now having that I see for an evaluation have already tried the GLP-1s, and either they can't tolerate the side effects
Right.
or they can't afford the medications.
Right. Yeah. Yeah. But even bariatric surgery, there is a time frame there too. Like usually after
Absolutely.
there's some weight regain. There doesn't have to
Absolutely.
be though. Like if the person follows a food addiction plan, which is just cutting out refined carbohydrates and sugars for the most part, not just, but that's all the 80% of the the gist of it. Um, uh, then it will be worthwhile. But it must break people's heart when they've gone to all that extent of surgery and now they're gaining the weight back because
Right.
they become addicted to alcohol or sugar. So
Right, and they haven't been educated ahead of time that this is a real possibility, and you really need to look at this addiction thing, and I know there are several of us who really, really hone in on that, but most people are like, "Well, that won't happen to me."
yeah,
That's not me, and then they learn the hard way. Some get help for it and some don't, but that's the same with all medical issues, right, and all addiction, but gosh, it saddens me, and I know for me personally, when after years of anorexia, right, and when you and I spoke, it was like my anorexic behavior absolutely met the criteria for food addiction,
uh,
and when I realized that if I don't do something, I'm gonna die, I
yes,
immediately started drinking.
uh,
Right, and from alcohol, I went to pain medication, opioids, so it was just switching out the way that I got that hit, and I was the one who always walked the line, who didn't lose everything.
uh,
So until a very wise therapist was like, "Well, no wonder this is happening. You're an addict." I'm like, "No, I'm not. Have you met my family? My family people, they're the addicts. I'm the success story." Oh my gosh.
that's
2
a big
minutes later, I was like, "Oh, that makes sense to me."
yeah, it sure does.
What a relief. It was like, "Okay, now I can treat it. What do I do?"
Uh, right.
But so
And
many people aren't aware.
it doesn't have to be a stigma. It's just that's it.
Mhm.
Like some people will say, I have a predisposition to being depressed or anxious, so I have to be aware of that. Like it's the same thing.
Absolutely.
Be more.
So, can you talk a little bit about eating disorders and the crossover with food addiction? Because I think in the food or in the eating disorder treatment programs,
Yeah.
sometimes there's a lot of damage being done because there's not an awareness or an acceptance of food addiction.
Yeah, so this is an unfortunate phenomenon way that like we've had disordered eating for a long time. Probably it matches the advent of the processed food industry, like in the 1940s, 50s. But for some reason, the eating disorder world, the medical world, which generally it's psychologists as opposed to MDs, got interested in okay, what is it that's causing this disordered eating? They kind of cottoned on to the idea of an eating disorder where essentially why is this person overeating? Well, they're using food to deal with previous trauma. It's kind of like comfort eating to the extreme.
Mhm,
And you severely restrict, things actually start to physiologically happen. Like we saw
mhm.
that concentration victims who weren't eating because they were in a concentration camp. They had to start having distorted images of themselves. They started thinking about food like they behaved in a different way. Like something physiologically happens when you're not eating, or similarly when you're eating too much. Um, uh, so the eating disorder model dominated. And then the food addiction model came around sort of in the 1990s, like 20, 30 years, 40 years after the eating disorder model. And it was a separate group of people. And we've been trying to find a way to work together. The eating
Mhm.
disorder model has this idea of it's a psychological issue, and you're using food, so you got to deal with the psychology. And on all foods, I think that the term is called all foods fit. Like you want to use all foods because once the psychology is resolved, you won't care about the food. You'll eat properly. And the food addiction people say, no, it's the food too. I mean, you might be right, but it's the food. But the good news is, Connie, because because it's dominant, if people actually seek help, they're most likely to go to an eating disorder clinic, which will say, eat candy and cake just in moderation. And you know, and I know that that doesn't work. And there's the battle. The good news is that now I still think the predominant model is eating disorder. Oh, something's happened to my screen. Sorry.
That's okay. It's a nice library.
I don't know what's happening there. So you know what? If you'll just excuse me a second, I'm going to use a
It's
different
really
camera.
okay.
That is funny. All right, it's a
There
little
you
different camera. Okay, so yeah, the good news is that there is now, at least in the research, and with some clinicians, more of an attempt to say, okay, let's do an integrated model between the two, where
Yeah.
it doesn't have to be either or, and that some people may have to just restrict completely particular foods, and others, it's kind of dangerous for them to do that. So can we be more careful? So I have hope that in the future, in the next 5 to 10 years, we're going to see a merging or integrating. But at this point, buyer beware, anybody who's listening. If you're seeking help out there, ask your eating disorder clinician if that's where you ended up, because that's where most of the money is being put.
Right.
How do you feel about refined carbohydrates and sugar, which are drug foods? And if they say, no, it's not, leave.
Absolutely. Absolutely. That is so scary and dangerous to me. And not everybody who has an eating disorder is a food addict. Vice versa, right? Everybody who has a food addiction doesn't, well, they have disordered eating, I would
Yeah,
say.
yeah.
Yeah. But as a psychologist, I don't think it has to be mutually exclusive, because there are people who may start out as I'm eating to comfort trauma, but develop that food addiction as opposed to that initial biological predisposition. But either way, the recovery is the same. It's get rid of the thing that's causing the surge.
Yeah. Yeah, and I think that there are some eating disorder clinics now who will say, okay, we don't want you to be afraid and restrict food, but we will acknowledge that we should all eat healthy. And that means you don't need to eat sugar and refined carbohydrates, which leads to the other thing that I think that we should mention, which is the new guidelines, the American dietary guidelines that have changed in the US.
Yes.
What, a month ago? Not even? I don't know.
Yeah, it was all over LinkedIn.
Yeah, and it's like amazing, like just that's so amazing that that's happened, because it means that refined sugars and carbohydrates are now not up on the top of the list, but at the bottom of the list of what we should eat.
Right.
Maybe because it's official. I mean, I don't know. I hope so. That means that in nursing homes and in schools and insurance platforms, foods that we think are basically food addiction friendly will be starting. It'll become policy. That's my hope.
Let's talk
And if the
about
American,
let's talk about artificial sugars in this whole food addiction thing, because sugar obviously is the number one culprit for most food addicts. What are your thoughts about the artificial sugars? People going, well, I'm not going to eat, real sugar or raw sugar.
that's one that okay, Connie, you got frozen there, so I might be frozen on your end.
Nope, you're good.
Okay, good. All right. Artificial sugars, I think, is in that gray area, that it's not an either yes or no. It is a bridge, and if it is the thing that gets a person to eat, are you still there, Connie?
Yep, my camera just went wonky.
You there?
Yep.
Okay, good. You blanked out there. Yeah, so I think artificial sugar is a bridge, and if it's the thing that if you're the clinician and that person says there's no way I can live without my pop and my whatever, say, okay, can you at least do diet pop? Can you at least do whatever? That's better. And it's on the rate. So it's like a harm reduction approach. I
Mm-hmm.
think
Mm.
it's probably easier in the long term to just stop. But there are some people that can, in real moderation, like just uh, have a little bit of a sweetener, I don't know, a couple of times a day, and it's not a problem. That it's probably okay. But don't get fooled into thinking that it's a solution. It's just less harmful because there's still an insulin spike, not as much, but there still
Mm.
is, and there's still a potential um, uh, fostering the craving of sweet because we want to be able to enjoy the sweet of vegetables and fruits on their own. And if you constantly have something that's slightly sweeter, you won't see the value of those because you've still got the sweetener. The good news for somebody thinking, how can I do this, is you won't need the sweetener once you stop it, is you'll realize, oh yeah, my peach or my apple is sweet enough. That's why I
Exactly.
like that's why I like my Facebook group. I'm sweet enough.
I
Sugar free.
love your Facebook group title. I'm sweet enough.
Yeah,
Absolutely.
I don't need it. But if I need it to get off the sweeter stuff, okay.
Exactly. So let's talk about the treatment for food addiction in your recommendations.
Yeah. So the treatment, it depends on how far along the line you are. I think that because it's an addiction, which is a mental hijacking, um, the number one thing is you have to stop the substance. And I know a lot of people, especially in the eating disorder world, will say, now you got to fix the problem, the psychological problem, the predisposition first before. I say you got to you got to stop the sugar
Yeah,
or the drug.
I
Um,
agree.
and so because it's really hard and I can't alone, then number one, you stop, and then number two, you get support so that you stay stopped. And that would be either the Facebook group or platforms where you like this. You listen to a video every day. You have a counselor. You go to 12-step where you have a meeting every day or something that is regularly there because
Right.
we are socially porous and you can stop a substance, but then when you go out there and you smell it and you see people eating it and all this stuff, we will just naturally absorb that. So you have to build a buffer, which is the support.
Yeah. Yeah.
And that treatment involves stopping the substance, and then what support do I need to stop that? I would love to see treatment centers, and there are a couple in the States that try to work around the eating disorder category so that they can do face food addiction as well. But
Right.
it's not covered overall. And until then, we're kind of stuck with outpatient treatment, which is great, but sometimes it's not enough.
Sometimes it's not enough. Exactly. Just like with any other drug, insurance companies here are going to say, try the outpatient. And then if we need a greater intensity of level of care, then we'll put you in an inpatient. But yeah, this is not something you can do on your own. You need that support. You need that constant immersion
Yes,
in the
crucial.
retraining. Yeah, it's a tough issue, but there are people like you who are diligent and people like me who are diligent in working to educate and provide the tools. And it's just a not yet kind of thing.
Yeah,
Who knows how long it is before, they're like, hey, sugar's going to kill you like that cigarettes, but
yeah.
we're getting
Well,
there.
we're hoping that if we can get the DSM approval of food addiction and the ICD in the Europe, then maybe it'll get covered. That will make a big difference. I think
Huge.
there's a lot of people that would, if they could go into treatment and have it paid for, they would do it. And then once you you build your supports, that makes a huge difference.
Oh my gosh. It's so incredible. That support is, I mean, it's absolutely essential. It's not like optional.
Yeah,
Like they say in the 12 steps, nobody can do this for you, but you can't do it alone.
that's perfect. That's
Yeah,
perfect.
yeah. So how do people contact you and be part of the I'm Sweet Enough?
Well, okay, so the Facebook group is free. It's I'm Sweet Enough Sugar Free for Life. Just try to join. I let almost everybody in. I only don't let in people that look like they're going to spam us.
Oh,
Some,
that's good.
some sugar industry people try to get in there and I say,
Oh
nah,
my goodness.
you're not getting in here. So there's that. There's my book, which, like I said, third edition is coming out. That's easy to get on Amazon. I have a YouTube channel where I have some lectures on food addiction available, and I don't know what else do I do. That's all I can think of right now.
I will put all of those links on the show notes for this episode, which will drop on Wednesday of next week, whatever that is. Today is the 16th. So that, oh, where's my camera? Okay. It will be available this week. So I'm telling you, listeners, Dr. Tarman truly is, in my estimation, and I've read a lot of the literature and a lot of the books, the easiest to understand and, experienced personally, professionally, and is dedicating her life to, helping people overcome this addiction and understand it. I really, really appreciate you. And I
Thank
thank you so much for being on the podcast again. And after the third book comes out again, then we'll do another, okay?
you. Do that, yeah. And if I could just say thank you to you because you're speaking to a population like the bariatric, post-bariatric clientele, and they really need to hear this message. So thank you for being there because, like you said, nobody else is doing this stuff,
Yeah,
especially in the areas where it's really needed. So thank you. Back to you.
you're welcome. All right. All right. So, everybody, get this book. I'm not kidding. Not kidding. Get on the Facebook support group with Dr. Tarman, and I'm looking forward to that third edition. All right. Thank you again, and we will talk again soon.
Thank you.
All right. Good night.